Good afternoon. What Croak brought stroke, caring for the post-stroke patients in the clinic. Our learning objectives for today's lecture are as follows. Number one, evaluate a post-stroke patient for risk of stroke recurrence. Monitor risk factors for stroke prevention strategies in the outpatient setting. Discuss appropriate pharmacologic secondary stroke prevention strategies in the outpatient setting. And formulate a non-pharmacological treatment plan for secondary stroke prevention, including diet, lifestyle modification, and rehabilitation. What's the stroke burden in the Philippines? 500,000 Filipinos will be affected by stroke, with an estimated cost of care of about $350 million to $1.2 billion. Healthcare primarily is private, and usually it's borne out of pocket by patients and their families. Now, this is an all-cause mortality in the Philippines in the year 2020 and 2021, which shows you that ischemic heart disease is still the number one cause of death in the Philippines, and cerebrovascular disease comes close, as well as your neoplasm. Now, what are the stroke burden risk factors? These are the most common risk factors, namely hypertension, diabetes, smoking, and dyslipidemia. Now, what's the risk and cumulative risk of stroke recurrence among patients who develop strokes? Now, this data showing the cumulative stroke recurrence after an initial stroke shows you that after 30 days, the pooled cumulative risk is 3.1%, and after 1 year, it's about 11.1%, 5 years, 26.4%, 10 years, 39.2%. Now, this study, this is a local study looking at patients from 40 to 79 years old with non-cardioembolic ischemic stroke within 30 days of symptom onset. The exposure was aspirin intake for secondary stroke prevention. And the outcome was a recurrence of stroke, but this was a prospective cohort study. And it showed that the cumulative recurrence-free survival for stroke at 1 year is 92% and 88% at 2 years. Stroke recurrence was associated with lack of effort to modify diet. Prevention of recurrent stroke are as follows: lifestyle modification, and of course, treatment of stroke is mechanistic. Now, what are the different classifications of stroke based on the TOS criteria? You have your large artery sclerosis, atherosclerosis, cardioembolism, small vessel occlusion, these are your LAPIOS, and of course, stroke of undetermined etiology. A mechanistic approach to secondary stroke prevention. We have your clinical cases. We have 4 clinical cases. 1 on small vessel disease, 1 in cranial artery stenosis, cardioembolic stroke, and finally hypertensive intracerebral hemorrhage. Our first case is a 48-year-old woman, right-handed, known diabetic, hypertensive, obese, and working in a call center. Her chief complaint in admission is left arm weakness of 60 minutes with spontaneous resolution of symptoms. She arrived at the emergency room 3 hours after the onset. Her vital signs were as follows. BP was 140 over 100 millimeters mercury. She had a normal and general neurological examination. Her imaging, which was an MRI, was normal except for atherosclerotic intracranial arteries. Diagnosis then was transient ischemic attack with an ABCD2 score of 6. Now, what is the ABCD score? This is a tool to predict short-term stroke risk after a transient ischemic attack. To be able to optimize to predict stroke risk within 2 days after a TIA, but also predicts risk up to 90 days. Now, the ABCD score with corresponding risk of stroke within 2 days are as follows. If it's 0 to 3, you have a low risk, 1%. 4 to 5 risk score, you have your moderate risk, 4.1%. And higher risk at 8.1% if your score 67. Clinical question. Among patients at risk for early recurrence of stroke or TIA, does combination therapy with clopidogrel and aspirin provide greater protection than single antiplatelet therapy alone? I'm going to present to you 2 studies which compares the dual antiplatelet therapy and monotherapy. This is the first trial, which is the CHANCE trial, wherein they start patients with 24 hours after the onset of a minor ischemic stroke and high-risk TIA. These were done in 5,170 patients in 114 clinical centers in China. The intervention was a combination therapy with aspirin plus clopidogrel 300 milligrams of day one, followed by 75 milligrams daily for 21 days. The comparator was a placebo plus aspirin 75 milligrams for 90 days. The primary outcome was stroke, ischemic, or hemorrhagic during 90 days of follow-up. This was a randomized controlled and multi-center trial. What did it show? It showed you that stroke occurred in 8.2% of patients in the clopidogrel plus aspirin group versus 11.7% of those in the aspirin group. And there was a 32% relative risk reduction with dual antiplatelet therapy. The next trial that I'm going to discuss is a points trial, wherein patients within 12 hours stroke were given a combination of aspirin 350 to 325 milligrams plus clopidogrel 600 milligrams on day one, followed by 75 milligrams daily from day 2 to day 90. The comparative drug was a placebo plus aspirin for 90 days. The composite outcome of ischemic stroke, myocardial infarction, death from ischemic events at 90 days. And this was a randomized, double-blind, controlled, and multi-center trial. But this was done in the Western Hemisphere. Now, what did it show? It showed you that there was a 90 days risk of major ischemic events was reduced in patients with dual antiplatelet therapy, 5% in the clopidogrel and aspirin combination, and 6.5% in the aspirin alone. However, caveat is that you have a higher risk of bleeding at 90 days than those with the dual antiplatelet therapy. Now, this is just a pathway which shows you the you can give dual antiplatelets. This is you could see this in the American Heart Association and American Stroke Association, wherein for patients with recent minor non-cardioembolic stroke with an NIHSS score of 3 or less than 3, or high risk TIA with an ABCD2 score of 4, dual antiplatelet therapy with aspirin and clopidogrel should be initiated within 12 to 24 hours of symptom onset and continued for 21 to 90 days, followed by single antiplatelet therapy. Patient was discharged eventually on dual antiplatelet, that's its aspirin and clopidogrel. Our next case is a 72-year-old man, right-handed, known hypertensive, who had a previous cerebrovascular accident, infarct, with an MRS of 0. She came in with a left-sided lupus. Diagnosis was acute CVA infarct, right MCA region, secondary to intracranial artery stenosis. NIH's score was 15. Patients with more than one intracranial stenosis and have a cerebral small vessel disease have a hazard ratio of 2.03 and 95% confidence interval. Now, this study shows you the dual antiplatelet therapy using xylostazol for secondary prevention in patients with high-risk ischemic stroke in Japan. This was a multi-center open-label randomized controlled trial. It shows you that the annual event rate for stroke was 2.2% on dual antiplatelet therapy with xylostazol and clopidogrel or aspirin versus an antiplatelet alone. And it shows you that the risk reduction is about 51% in those patients receiving dual therapy. Now, what are the recommendations for patients with stroke and intracranial artery stenosis? Now, this recently came out in the Stroke Journal, wherein the American Heart Association and American Stroke Association came out with this recommendation. In patients with stroke or TIA attributable to 50% to 90% stenosis to a major intracranial artery, the addition of xylostazol 200 milligrams per day to aspirin or clopidogrel might be considered to reduce recurrent stroke risk. This is a level 2B evidence. So patients was eventually discharged on clopidogrel once a day and xylostazol 100 milligrams daily, twice a day. Our third case is an 83-year-old woman, right-handed, hypertensive, and with a known case of permanent atrial fibrillation, who had a CHA2DS2-VASc score of 4 on rate control strategy, though, but with no anticoagulation. She presented with right facial asymmetry 14 hours prior to admission, and likewise also had the inability to recall names of relatives. No other focal deficits was noted. This shows you the cranial MRI of this patient, as well as your cranial MRA. The diagnosis was acute cerebrovascular axillary infarct, right middle cerebral artery, probably cardioembolic in origin. Patient was started on statin, and the repeat scan on day 3 post-ictus was done, as well as rehabilitation. Clinical question. What are the predictors for early stroke recurrence among patients with atrial fibrillation? Risk factors for early recurrence of stroke in patients with non-valvular atrial fibrillation are the following: large lesion and imaging, high NIHS score, high CHA2DS2-VASc score, left atrial enlargement, the presence of intracardiac thrombus, and left ventricular obstruction. The CHA2DS2-VASc score is a predictor for a patient's 1-year risk for a trauma-embolic event. And this is as follows. If your CHA2DS2-VASc score is 2 or 3, it's 2.2% or 3.2%, and if it's 4, it's 4 or 5%. Thromboembolic event after 1 year or within a year. Now, this is the Hesbled criteria, which shows you the different characteristics of patients who are prone to bleeding, especially if they have hypertension, abnormal renal and liver function, previous stroke, previous history of bleeding, labile INRs, elderly more than 65 years old, and patients who are exposed to drug or alcohol. Now, this is a risk stratification tool for bleeding among patients on oral anticoagulation. Now, the Hesbled score is really more for correcting risk factors rather than shying away from anticoagulation because of the presence of your different risk factors. Clinical question. Among patients with acute ischemic stroke secondary to cardioembolic cause due to non-valvular atrial fibrillation, when is the best time to start or resume anticoagulation for secondary stroke prevention? This is a trial, which is the RUF study, which shows you the early recurrence and cerebral bleeding in patients with acute ischemic stroke and atrial fibrillation. Patients with acute ischemic stroke and known or newly diagnosed AF, the total number of 1,029, and the exposure was anticoagulant use for secondary stroke prevention. Composite outcome of stroke, TIA, symptomatic systemic embolism, symptomatic intracranial bleeding, and major embolism. This was a prospective cohort study. What are the results? It shows you that initiating anticoagulant treatment between day 4 to 14 from acute ischemic stroke is both safe and effective compared with starting before or after this period. Now, another trial, which is the RAF NOACS trial, which primarily looked at the utilization of NOACS in patients with non-valvular atrial fibrillation. They studied 1,127 patients, and NOAC initiation was done within 14 days of stroke. Again, composite of stroke, TIA, systemic embolism, symptomatic intracranial major bleeding, and major bleeding were the outcome. You can see in this slide that shows you that the ischemic outcomes and the hemorrhagic outcomes mostly occurred before, if the anticoagulation was started before day 4 and after day 14. Similar to the other one. Now, what are the recommendations of anticoagulation initiation in patients with stroke associated with atrial fibrillation? Actually, there is none. In the ESO, there is no recommendation. We're encouraged to include patients in randomized controlled trials. The American Stroke Association, 2021, it is reasonable to delay initiation of oral anticoagulation for 14 days after stroke onset. And then the European Heart Rhythm Association, they also have no recommendation. You have to weigh the risk of bleeding versus benefits for stroke prevention. Now, this is a Dinner's rule, which actually we follow here in the Philippines. This is restarting or initiating NOACs after an acute ischemic stroke in patients with non-valvular atrial fibrillation. population. Your patient comes in with on day one having TIA or mild stroke or an NIH score of 0, then you can start your anticoagulant drug right away. After 3 to 5 days, if your patient has minor or non-disabling stroke with an NIH score of less than 8, and moderate stroke 6 to 8 days, and after 12 days or more, this is they call this Dinner called this the 1-3-6-12 rule. However, he recommends to repeat imaging studies to detect presence of hemorrhagic transformation prior to resumption of or initiation of oral antibiotic. Now, what are the risk factors for hemorrhagic transformation? Usually, these are seen in patients with massive cerebral infarction or in area of the infarction cortical versus subcortical, atrial fibrillation and cerebral embolism, higher NIH score, hyperglycemia, low total cholesterol and low density lipoprotein levels, lower platelet count, poor collateral vessels, and those with dense MC design. Now, this is the Heidelberg bleeding classification done in 2015. It shows you the various hemorrhagic picture or conversion, which is your H1 and H2, and then your parenchymal hemorrhage, which is your PH1 and PH2. So patient, before discharge, you should repeat your CT scan on day 3 post-ictus. And if there is no hemorrhagic transformation noted, patient was started on apixaban 2.5 milligrams twice a day on lavavascular 80 milligrams daily. Our case 4 is a 78-year-old man, right-handed, hypertensive, diabetic with CKD stage 4, known case of vascular dementia. And this cranial MRI shows you a thalamic hemorrhage on the left side. Clinical question. Among patients who suffered from hypertensive intracranial hemorrhage, is an antiplatelet for secondary stroke prevention contraindicated? This is a trial, which is the RESTART trial, which shows you the effects of antiplatelet therapy after stroke due to intracerebral hemorrhage. This is a randomized open-label trial wherein patients with ICH numbering to 537 were given antiplatelets, either aspirin or clopidogrel, and compared to patients who had no antiplatelet consumption. Outcome was a fatal or non-fatal radiologic, pathologic proven recurrent symptomatic ICH. Secondary outcome was composite of all major hemorrhagic events, composite of all major occlusive vascular events. This was a multi-center, randomized controlled, open label trial as well. Now, what's the result of the RESTART trial? There is no significant difference in risk of bleeding if patients were restarted with antiplatelets or not after an episode of intracerebral. What are the other aspects of post-stroke care after critical care phase? Post-stroke depression, rehabilitation, lifestyle modification, control of comorbid symptoms. Now, what is post-stroke depression? It is usually present in 31% of stroke survivors at any time until 5 years after the stroke. This usually leads to suboptimal recovery, recurrent vascular events, poor quality of life, and even mortality. So what are the predictors of post-stroke depression? Usually, patients are physically disabled, the stroke severity, and a previous history of depression and cognitive impairment. And of course, major to this is lack of family and social support and anxiety after stroke. Amongst patients who should be screened for post-stroke depression, post-stroke patients with 2 weeks or more history of depressed mood or loss of interest or pleasure along with the following: weight loss, insomnia, psychomotor agitation, fatigue, feeling of worthlessness, diminished concentration, and of course, patients with suicidal ideation. When is the timing of screening? It could be done from after the patient is transferred from the acute setting to an inpatient rehabilitation setting. In inpatient rehabilitation setting, before returning to the community, secondary prevention clinic visits. Following discharge in the community during follow-up appointments with consulting specialists and during periodic health assessment. Now, what are the screening tools? Optimal screening tool is still unclear, but usually you can use your 9-item patient health questionnaire, which is the PHQ-9. Here it shows you 9 items, wherein you can see that the following is there little interest or pleasure in doing things, feeling down, depressed, and hopeless, trouble, failing or staying asleep or sleeping too much, down the line. Now, how do you treat PSD? The recommendation is cognitive behavioral therapy as one of the first line of treatment, which is level B evidence. Psychotherapy as adjunct to antidepressants, level A, and pharmacotherapy should be considered and started if the depression is persistent or worsens and interferes with clinical goals. People diagnosed with depressive disorder following stroke should be considered for a trial of antidepressant medication. Response should be monitored regularly. If there is good response, treatment should be continued for a minimum of 6 to 12 months. What about rehabilitation? Rehabilitation in acute ischemic stroke, early rehab for hospitalized stroke patients should be provided in environments with organized interprofessional stroke care. This is class 1 level A evidence. And you have for stroke survivors should receive rehabilitation at an intensity commensurate with anticipated benefits and tolerance. High dose, very early mobilization within 24 hours of stroke onset should not be performed because it can reduce the odds of favorable outcome at 3 months. What about in patients with intracerebral hemorrhage? Patients with spontaneous ICH, multidisciplinary rehabilitation should be performed to improve functional outcome and reduce morbidity and mortality. With spontaneous ICH with severe severity, early rehab beginning 24 to 48 hours after onset may be considered to improve functional outcome and reduce mortality. However, spontaneous ICH, very early and intense mobilization, particularly within the first 24 hours, is associated with lower likelihood of good recovery. What about lifestyle modifications? Well, you have your diet, Mediterranean type diet. Sodium intake at least 1 gram per day of sodium, which is 2.5 grams per day of salt, which is equivalent to 1 teaspoon of salt actually. And then which is your dust diet. And then your moderate intensity aerobic activity and of course, smoking cessation. What about control of your comorbids? For hypertension, BP goal should be less than 130 over 80, which is level 180. And you can use your thiazide, AC inhibitor, or angiotensin 2 receptor blockers, which are useful for lowering BP and reducing recurrent stroke risk. For dyslipidemia, the target goal is less than 70, and the use of atorvastatin, 80 milligrams per day, is indicated to reduce stroke recurrence based on the Sparkles trial. Now, this is the flow of your early secondary stroke prevention. For non-cardioembolic, minor stroke NIHs, 3 or less, or high risk TIA, ABCD, Satorum 4, you can use dual antiplatelet therapy for 21 to 90 days, followed by antiplatelet monotherapy. And for cardioembolic strokes, antiplatelet monotherapy can be started for the first 48 hours. And then after that, oral anticoagulation can be started in 3 to 4 days among mild cases, 6 to 7 days among moderate cases, and of course, in severe cases, at least 12 to 14 days after. In summary, cerebrovascular disease remains to be the second leading cause of mortality in the country. We have a very high burden of stroke in the Philippines. Treatment of stroke is mechanistic. For acute ischemic stroke, consider dual antiplatelet therapy for patients with atherosclerotic intracranial arteries. Anticoagulation may be safe, may be considered from day 4 to 14 after a cardioembolic stroke due to atrial fibrillation. Number 6, restarting an antiplatelet may be safe and may reduce recurrent ischemic events in patients who had hypertensive intracerebral. 7, always screen patients for post-stroke depression. Rehabilitation may be done 48 hours from stroke onset after readiness for the program has been assessed. Finally, diet modification, physical activity, and control of comorbid conditions are important non-pharmacologic strategies to prevent stroke recurrence. Thank you very much for listening.